Critiquing Research for Clinical Change. This presentation was put together and presented by Felix Polyakov. Nosocomial infections are a big drain on healthcare services and costs. A serious nosocomial infection is ventilator-associated pneumonia, also known as VAP. VAP can increase duration of mechanical ventilation, intensive care unit length of stay, hospital length of stay, and mortality for patients, which should be preventable with evidence-based care. Ventilator-associated pneumonia, for example, occurs in up to 25% of endotracheally intubated patients. VAP can occur 48 to 72 hours after a patient is intubated. It is attributed to pathogenic bacteria and dental plaque which colonize the oropharynx. With intubation, the patient is more likely to aspirate these bacteria into the lower airways, causing the infection. One of the preventative treatments currently used and extensively studied is chlorhexidine, though currently there is no gold standard for concentration or application frequency. My original PICO question was, would performing oral care using chlorhexidine mouthwash every 8 to 24 hours versus the standard of every 4 hours affect the incidence of ventilator-associated pneumonia during the first 7 days following intubation in the ICU setting? As I was doing research, I found that CHX had been found effective in research studies that used different application schedules. I was interested in finding how important the application schedule was. Is applying CHX a few times a day necessary to prevent VAP? Or was it more important for the patient to start receiving CHX oral care as soon as possible? So my final PICO question became, would performing oral care using chlorhexidine mouthwash within 12 hours of intubation for standard oral care affect the incidence of ventilator-associated pneumonia during the first 48 to 72 hours following intubation in the ICU setting? During my research into my PICO question, I accessed the search database CINAHL. The search terms I used in finding my article were chlorhexidine, ventilator-associated pneumonia, and oral care. The article I chose was Early Single Chlorhexidine Application Reduces Ventilator-Associated Pneumonia in Trauma Patients. This article was published in Heart and Lung, the Journal of Acute and Critical Care, in 2011. The purpose of this study was to determine if the use of early single application of CHX reduces incidence of ventilator-associated pneumonia. The study focused on evaluating the effects of CHX in the single oral application within 12 hours after intubation of development of VAP at 48 hours and 72 hours of intubation as compared to a control group which received only standard oral care without CHX. The baseline and outcomes were measured by the Clinical Pulmonary Infection Score, or CPIS. CPIS measures 6 parameters, which include body temperature, white blood cell count, tracheal secretion, oxygenation, chest radiography, and tracheal aspirate culture. Each of these parameters is given a score of 0 to 2, adding up to the final score that can range from 0 to 12. If the score is 6 or greater, it signifies that VAP is present. The study initially enrolled 152 patients, but due to various reasons had only 60 patients for final analysis. They found that performing oral care with CHX at least once within 12 hours of intubation was an effective intervention in decreasing incidence of VAP. This study was a randomized control trial and falls into level 2 on the hierarchy of the evidence pyramid. This study used an intervention and control group to establish the cause and effect of the intervention and outcome studied. It was prospective in that it looked at the relationship between CHX as an intervention and VAP as the outcome. It was longitudinal because it studied the same group of participants over a set time period. Another important aspect of RCTs is effectively randomizing the participants, therefore decreasing bias. After participants were found eligible for the study, they were randomized using the block randomization scheme into a control group and an intervention group. This scheme takes a specific number of patients at a time and assigns them into blocks. The computer then takes the blocks of patients and assigns them to the groups randomly, but ensures that there are equal numbers in each group. The example shows if the computer took a block of 4 patients and then randomly assigned them to either the control or the intervention group. As you can see, each group of 4 patients is equally but randomly distributed into either group, 2 in the control group and 2 into the intervention group. The appraisal tools used to critique this study included the rapid critical appraisal questions for randomized control trials and the overview questions for critical appraisal of quantitative studies. Characteristics of the study that add to its validity include the patients being randomly assigned to each group, the pulmonologist reviewing the chest radiographs was blinded as to which patients had received a treatment of CHX and which had not. This study adds to the already growing number of research that focuses on the use of CHX in the prevention of VAP in ventilated patients. Nurses being blind to which patients were receiving CHX treatment could have added to the validity of the study. At the time of the study, CPIS was an accepted method of evaluating VAP, but after the study was done, it has come into question as a reliable tool to diagnose VAP because it is difficult to differentiate pulmonary inflammation associated with thoracic injury or sepsis from pneumonia. The authors strengthened the reliability of their study by giving detailed accounts of the numbers of participants, including those that were lost and why they left the study. They also provided a statistical analysis using the p-value to show that the likelihood of their findings being attributable to chance is very small. According to Melnick and Feinout-Overholt, a p-value of 0.05 or less means that it can be assumed that the study findings are not a result of chance. At 48 hours, the p-value between the control and intervention group CPIS results was 0.020, and at 72 hours, 0.027. This study is applicable to patient care. It is feasible and easy to add to care even during the hectic hours immediately following intubation. Though there is a risk of aspiration with the 5 milliliters introduced into the oral cavity, it is outweighed by the benefits of preventing VAP and its concurrent complications. Patients and their families come into the hospital with expectations for treatment and healthy outcomes. Nosocomial infections are not something they want to deal with. Although this is a high-level study, there are still some limitations. This is the only study to research an early single application of CHX to intubated patients. Its sample was comprised of patients from ICUs at a single hospital, so it is not a good representation of all patients who are at risk for VAP. Since the study was done, CPIS has been questioned as a gold standard tool for measurement of VAP. Change in clinical practice cannot be recommended by this one research study due to its limitations. There have been numerous studies done on using CHX in preventing VAP for intubated patients with positive outcomes, and this study adds to that knowledge base. However, further studies need to focus on finding the best concentration and application schedule. These studies should be high-level randomized control studies. There should be an overview and comparison of multiple randomized control studies to create the best standard of practice. To implement CHX application in the hospital, the Iowa model of evidence-based practice to promote quality care would be a good model for a change plan. The Iowa model begins with the trigger, in this case intubated patients developing VAP. Nosocomial infections are a priority for hospitals, so a multidisciplinary team can be put together to find research on the topic and critique for applicability in solving the trigger problem. Once sufficient evidence is found to form practice standards, the multidisciplinary team puts together pilot studies. If the changes evaluated are positive and appropriate, the change can be written into standard practice and policy. Please feel free to post your questions in the discussion forum.